When a patient leaves a hospital, it's not just a medical milestone, it's a medico-legal statement. In this video, we decode the different types of hospital discharges and why using standardized terminology isn't just helpful, it's essential. Discharge is the process where the patient moves from hospital to home or another healthcare facility. In today's healthcare environment, how we document discharges isn't just a bureaucratic necessity, it's a powerful medico-legal safeguard. Broadly, when a patient leaves the hospital, it can happen through a planned discharge, a transitional care discharge, that is referral, a discharge against medical advice, or the patient may abscond. Each of these have distinct clinical and legal implications. Planned discharge and transitional care discharge are consensual, while discharge against medical advice and abscond are non-consensual forms of discharge. Let's look at planned discharge. This is the routine discharge of a stable patient who has sufficiently recovered from illness or surgery. It might be initiated either by the doctor or the patient. Often, patient requests discharge when they feel better. If the doctor agrees, this is still a planned medical discharge. Planned discharge also includes patients requiring medical care, monitoring, or assessment activity after leaving the hospital. So when a patient requests for discharge, the important question to ask is, can the patient be followed up on OPD basis or via teleconsultation? The term discharge on request should be avoided because legally the responsibility still lies with the doctor who has the medical expertise to decide if discharge is appropriate. Using casual or ambiguous terms can lead to legal complications. Common medico-legal issue in using the term discharge on request includes denial by patient or family of having requested discharge or claims that risk was not properly explained. So, the ideal term to be used is planned discharge. The second type of discharge is transitional care discharge, also known as referral discharge. This occurs when the patient is transferred to another facility, typically due to the need of specialized, intensive, or long-term management. This must be clearly documented as a planned or coordinated referral, including the name and level of the receiving institution or department ideally. Third type is discharge against medical advice. Here the patient initiates the discharge despite the doctor advising against it. The patient may still be unstable or need the treatment but insists on leaving. This is a high-risk event and must be handled with both clinical and legal care. Healthcare providers must balance patients' autonomy with their duty of care. A structured and ethical model like the aimed approach can help. Aimed approach stands for A. Assess, that is, evaluate how sick the patient is, confirm the decision-making capacity. I. Investigate, ask, why do you want to leave before your care is complete? Understand personal, financial, or discomfort-related reasons without judgment. M. Mitigate. Offer alternatives acceptable to the patient. Provide maximal necessary care and follow-up instructions. E. Explain. Communicate the original plan, the risks of leaving, and alternatives. Provide written instructions for warning signs and return. D. Document. Note clinical findings, capacity assessment, and patient refusal. Get a signed discharge against medical advice certificate co-signed by second doctor. If a patient or relative refuses to sign, obtain two witnesses' signature. Record clearance of dues or note promise to pay. The last type, absconded patient. They are ones who leave the hospital without permission or notice, often in a state of incomplete or critical care. The hospital remains legally responsible for a patient in its custody, and if the patient who has absconded deteriorates, commits suicide, meets with an accident, or commits a crime, the hospital may face legal scrutiny. So the protocol to be followed: inform the medical superintendent and hospital administration, notify the police without delay, document the information provided to the hospital administration and police. Important points to note: all the 4 types of discharges should have a standardized operational protocol customized to the healthcare facility. Discharge is not a termination of care. Patients have all the legal rights to access their medical records even if they have absconded. Though the term leaving against medical advice is used often interchangeably with discharge against medical advice, it also includes abscond. Thus, the term LAMA, that is leaving against medical advice, is vague, just implies a non-consensual form of discharge and should be avoided. Benefits of using standardized discharge terminology: establishes clear communication on required actions among doctors, nurses, administrative staffs by removing ambiguity, especially during referrals. Consistent usage of terms enhances patients' understanding, ensures uniformity across all departments and staff entries. A clarity on the consensual aspect of the discharge enables the staff to utilize risk reduction strategies such as appropriate documentation of communications, consent forms, witness signatures, and patient instructions. This practice helps in painting a clear picture in the court if required. A standard terminology usage provides clear data set which enables comparison between units, departments, and even hospitals for benchmarking and quality improvement. This also enables research and health policy focusing on enhancing patient experience. Discharge is not just a clinical event, it's a legal handover. To ensure safe, ethical, and defensible practice, always use clear and standardized terminology, ensure documented communication, follow hospital protocols, escalate concerns without delay. Protect your patient, protect yourself.